Good morning, class. This is Professor Streb, and I'll be doing my Unit 3 recap and review voiceover that you can listen to in your car or on your phone or wherever you find yourself with some downtime. As always, I highly recommend that you use these as a good starting point for what to review in your book and to kind of focus on what the nurse's role is. This week, it's about caring for patients with infections, patients experiencing inflammation, the patient receiving total parenteral nutrition, so TPN, blood and blood products, and the care of patients who have central venous access devices. In your syllabus, it has the page numbers listed and the topics that you're responsible for, so make sure you go through and look at those pages in order to find out what is super important. So the first part of the syllabus talks about infection and inflammation. This is a big topic. As nurses, you have to be aware of infectious diseases, and you have to be very diligently on top of it. Not only treating the diseases and treating the issues that are going on, but also in the prevention of diseases. And prevention, it focuses a lot on patient teaching. So we're going to get into a lot of that as well. We know that inflammation and the inflammatory process attacks the body's protective mechanisms that no longer work to maintain that homeostasis, if you will. So when we're looking at these type of patients, we're trying to figure out who's at risk for what. That's a big thing we're talking about. And it's something that we have to really focus on when we start looking at people who are overwhelmed. If you think about patients who have an overwhelmed immune system, it could be people who have cancer. So somebody with a low WBC count and very neutropenic could put them at risk for infections as well. Malnourished patients. If you have somebody who's not eating enough, we know that total protein, and we look at that with our prealbumin levels, total protein, that malnourishment puts you at further risk for infection and inflammation. Chemical dependency, so if you know an alcoholic, somebody like that can also be at further risk and increased risk for infection in the inflammatory process. So, take it individually, you have a problem, then you start adding these together, having comorbidities. You have a cancer patient who is now malnourished because they didn't want to eat, and they've also been an alcoholic their entire life. These things start adding up where now they're at the greatest risk for developing an infection. So that's kind of where you have to get your mind set as you're going through these PowerPoints and you're reading the pages. We know that hand washing, as evidenced by the first nurse out there, when we started thinking about modern medicine, it all kind of started there in New York City, there on Ellis Island, when Florence Nightingale decided that washing your hands was the way to go, and it worked. So wash your hands. Meticulous hand washing and drying is the best way to really get rid of everything. We know that you have to rub your hands vigorously as you wash to get all the oils, the bacteria, the soil off. That is something that you must know. Not just you, but when you have your CNAs coming through, your unlicensed assistant personnel. If you watch them washing their hands and they're just, halfway doing it, is that really good enough? You as the registered nurse now have to be on top of people to make sure that they're not infecting your patients. So good things to think about. Also, the use of hand rubs. When you go in to take vital signs, clean hands in, clean hands out, those alcohol rubs are fantastic. But there are times when they're not used. And some of these times include, like if you have something like C. diff, you would have to actually use soap and water to get that infection off your hand and to get that microbe into the sink and down the drain. So, but for the most part, the use of hand rubs, before and after seeing the patient is typically fine. It just depends on what kind of, precautions they might be on. You should always wear gloves. This is part of our competencies when we're in lab. Wear gloves anytime you touch bodily fluid. When you touch blood, bodily fluid, secretions, anything that's contaminated, the bed sheets, a Chuck's pad, you're taking off a dressing, that too can be contaminated. It's always a good idea to do that, right? So put on clean gloves before you touch anything. If you touch the feet first and then you go back to the eyes or the mouth, you should change your gloves out. If you're touching non-intact skin or anything, like I said, any moist bedding or personal objects, you need to be wearing gloves. You need to wash hands before and after and change gloves frequently. So like I said, there are times when you need to be more diligent. Like I said, if you're just doing something that doesn't involve patient care or touching bodily fluids? Do you have to wear gloves? The answer is no. Can you? The answer is yes. Always wash your hands, clean hands out. Make sure you're using the rubs after touching equipment and stuff. But if you're touching a patient who might have a disease process that lingers like C. diff, make sure you're using soap and water. You have to wear mask and eye protection anytime that you're working around somebody's mouth and their eyes or their nose, where they could sneeze or cough and get their fluid into your mucous membranes. So things to think about. Also, gowns are important anytime that you might get exposed to splashes of blood or bodily fluid. You put in a Foley catheter. That could be something. It just all depends on what we're doing there. And then lastly here, infections. When you have an infection, one of the earliest signs you're going to see, or one of the telltale signs, is WBCs that are elevated above the normal range there. So always pay attention to your labs. They're going to be very important. Just kind of know what's going on. Also know who's at risk. I mean, think about people. I think a few years ago, the big thing before we had coronavirus was people who had traveled outside of the U.S. and we were worried about them, coming down with certain diseases based on where they traveled, right? So we know that people can go to other places. They can get malaria, they can get Zika, they can get all kinds of diseases. So think about a patient who might have traveled in the last 2 weeks to attend whatever, a family function, or they were just going on travel for pleasure. Certain countries are going to raise a red flag where you should be, this person should probably be isolated based on whatever the CDC recommendations are for these countries. So pay attention to, your patient history as well and what they're telling you. This is going to be huge. I can't stress the importance of your precaution types. It is not enough just to understand that there's contact precautions, there's airborne precautions, and droplet precautions. You need to go deeper. On contact precautions, you need to know exactly what that means. You need to be able to tell somebody what is involved in contact precautions. Think about a newly hired CNA. They might not know. The patient, their family, they might not know. So when you think about contact precautions, it's not just what's going on in the hospital. Yes, you and I both know that contact precautions require you to wear a glove and a gown when you go in the patient's room, right? You can't have direct contact with anything the patient has touched, because if they have something like MRSA, then you could get MRSA as well. You also need to teach your patients not to share or reuse their clothing, their bedding, toiletries, things like that. When they go home, their spouse should not use their washcloth or their towel after they use it. As a matter of fact, the patient shouldn't be reusing those things, because you can continue to spread that disease process around. Sleeping in the same bed, not a good idea. If they have MRSA that is draining and it gets in the bed sheets and their partner rolls over, they too could get infected with MRSA. So it's going to be important for you to know the 3 things that I'm about to tell you. You need to know what the precaution type is, what diseases fall underneath the contact precautions, and what steps and what equipment are required under each of these precautions. Airborne precautions. This is one where people get confused. I look at airborne precautions and I say the same thing always. I use the acronym MTV, just like the music television channel MTV. And we talk about measles, tuberculosis, and varicella being the 3 disease processes associated with airborne precautions, right? So these are the ones that can be transmitted through the airborne route, just breathing. They leave your mouth and they go out. We know that. How do you protect your patient? Well, we know that they have to be in a negative air pressure room. You got to keep the doors closed. As you go in and take care of these patients, you're supposed to wear like an N95 mask, some kind of HEPA filter type mask. There's a HEPA filter in the room that helps clean that air so nobody else gets infected. So that's part of it. Also, if your patient has an active airborne disease and they're on airborne precautions, when you transport them somewhere, it's going to be important that that patient has a surgical mask on to minimize the risk of exposure. No different than we do in class now with COVID-19. We wear a mask to limit our exposure of other people. So you don't know if you have it or not sometimes. Same with TB, same with measles, and like I said, the herpes zoster or varicella, chickenpox. There's a lot of names people use to talk about varicella. So depending on what test you get, and if you're on ATI or NCLEX, I don't know how they would word that for you, but it's just something to think about. So make sure you understand what to teach the patient as well. These are going to be very, very important. All right. What else are we talking about here? Droplet precautions is the last one. Droplet precautions are anything else kind of that come out of your mouth or nose that's not your MTV, that's not your, your measles, your tuberculosis, your varicella. So that's your airborne. Droplet is pretty much everything else that comes out via coughing and sneezing. You actually have to have a projection. So you have to have this force in your oral or nasal passages, and it comes out and it generates enough force to push an aerosol out. And these organisms can live and travel up to 3 feet. So like pneumonia, we know that pneumonia, influenza, meningitis, now most recently, Ebola, that was one that we had previously, if you went to Liberia or something like that in the last 14 days, anywhere in Africa, certain countries, you have to be worried about that. You'd have to, let the administration know, put them on droplet precautions and contact precautions. So there are different things to think about. You can't just know what they are. You need to know what diseases are included, because you might get a test question that says a patient was diagnosed with blah, blah, blah. What would be the appropriate precaution? Or your patient is on airborne precautions. What would you teach the family? That's the kind of questions you're going to receive, right? We're not going to ask you to memorize stuff. We're going to make them real world scenarios. So when you look at droplet precautions, make sure you know which diseases fall underneath that as well. When you start thinking about infection control and you think about your job as a nurse, understand that when you have to wear a surgical mask when you get close to somebody who's on droplet precautions. If you're within 3 feet of them, you need to have a surgical mask on as well. This is important for you as the registered nurse, because now you're the expert. You're going to be teaching your LVNs. You're going to be teaching your CRNAs, anybody else who comes in the room. That is your job, the nursing process, teaching. That's something you have to do. All right, blood types. This can be confusing for a lot of people, but it doesn't have to be too confusing. We're not going to just hit a lot of questions on this, but we want to make sure that you are safe. Before you ever hang blood on any patient, and I'll get to more of it in a little while, you have to know the blood types first. You just have to. Think about you're a nurse and you're assessing your client. It's change of shift. You get there, you walk in the room. The nurse before you told you they hung the first unit of blood. It's been going for 30 minutes, whatever. You walk in and you notice that the client's blood type is, just choose one, and then you look and the client's receiving a blood product that is not compatible. So let's just say you're a blood type, let's just go with O, right? O positive, O negative, you choose. And then look, who can they not receive from? They can receive blood from other O people. What if they're getting blood from an A person or an AB person? That should immediately cause pause in your mind, and you should stop that infusion right away. Just stop it completely, and then do all the other steps the book talks about as far as getting blood samples, sending that off to the lab with the tubing, etc., etc. If you don't know what blood type is compatible with other blood type, how are you going to know if it's safe or not? Yes, in real life you're going to look that up, but on exams you're going to have to know these type of things. We know that O can give to anybody. It is the universal donor. We know that O can only receive O, right? Pretty easy on that one. We look at the other ones. We look at AB. AB can receive from anybody. It can be A, B, O. It kind of goes there as well. They can get a little confusing. I get it, but just do your best to understand. And especially the main ones. We know that a lot of people are O positive, O negative, things of that nature. So do your best, but know your universal donors and your universal receivers. That really takes a big chunk out of this. All right. Carrying on with blood products and infusion therapy, there's a lot to this as well. Why? Because this is where you're going to do a lot of what you do as a nurse. And as we know, we are going to focus on what your job is as a nurse, because ATI wants you to focus on what your job is as a nurse, because NCLEX ultimately wants you to know how to be a safe nurse when you graduate. You don't have to be great, but you have to at least be safe. So when you're thinking about blood products, you have to assess your patient's vascular status first. Make sure that they're able to circulate blood, that you wouldn't overwhelm their system. And that's the first step. If their heart rate is 40 or whatever, are they really going to perfuse like they should? So you need to think about these things first. You make sure they have good IV access, that you can run fluids through, and not cause that vein to collapse or break or blow or whatever else. Once you start an infusion, there's a lot you have to do first. So when you're preparing to administer these packed red blood cells, like I said, you really have to assess your patient first. Make sure they're in good status and they're in good circulatory health before you start transfusing. Once you get the blood from the blood bank, you have 30 minutes to start infusing it. And then after that, you have about 4 hours to make sure from start to finish, the blood is infused completely into the patient. If you don't start within 30 minutes or return it to the blood bank, you just wasted a lot of that tissue that could be used to save somebody else. And if you don't get it infused within 4 hours, you also waste that. So this is a hot commodity and one that we don't want to waste because people are donating their own tissue through blood transfusions and donating this way. All right. So you know that vital signs must be checked after, at least the first 15 minutes, then 30 minutes, and then once an hour. And you want to continue checking those hourly until the transfusion is done. You as the registered nurse must be the person who starts the blood product. Once you did your 15-minute check, then you can delegate to the LVN to go back and continue monitoring the patient, because now the patient is no longer considered critical because we got through that first 15-minute phase, and they shouldn't have any more there shouldn't be adverse reactions happening past that point. All right. Patients can only receive blood products compatible with their blood type. I can't stress that enough. You're going to have to figure out, a nursing intervention for somebody, like I said, who's O positive receiving A blood. You would have to discontinue that infusion completely. You would have to hang a new bag of normal saline in a new IV line and then start transfusing that. You'd have to get rid of anything that was already in the other lines. Fresh frozen plasma, or FFP, is another component that we use of blood. It's not the packed red blood cells or whole blood, but it's the plasma portion. This is one that's a little bit different. It's one that we administer rapidly, as fast as the patient can tolerate it, and it's to treat the bleeding associated with PT that is too high. We know that a normal PT, we have to look at these. So make sure you know your PTs, greater than 1.5 times normal would be too high, or an APTT that's 2 times greater than normal. When we have people who have these clotting issues, sometimes we have to give the fresh frozen plasma to really kind of counteract that. So be sure you understand how to administer fresh frozen plasma as well. It's used to replace those clotting factors because we don't want our patients to bleed out. All right. Monitor for signs and symptoms of infusion reactions. When you're in that first 15 minutes, you're going to look for headaches, chills, shortness of breath, hives, warmth over the body, over the insertion site, generalized itching. These are going to be your telltale signs that your patient is having an infusion reaction. It doesn't have to be just the blood. Some of these also apply to medications that you're giving somebody. So kind of think about it. If your patient's having an infusion reaction, we're talking about blood here, but you can also take some of this with you on other infusions as well. All right, lastly on this, make sure that you're using the right equipment before you start hanging blood. You have to have a good IV access. It needs to be, peripherally inserted. The bigger the vein, the better off you're probably going to be. So we need to use a large bore IV needle, at least a 20 gauge. You can go up to 18, 16. It depends on where you're at, but a 20 gauge, anything smaller would cause those hemoglobin hematocrit, the red blood cells, as they're going through, they can get lysed and break down, and then they're no longer effective. So this is definitely something that you want to pay attention to, is the IV needle size. At least 20 gauge, 1 to 1 1/4 inches in length. Those are what you have to make sure you're using. If you don't, then you run the risk of causing problems with the blood going in and then causing clots in your patient, which could eventually lead to them dying if you're not careful. Veins that should be considered for peripheral cannulation are those on the dorsal and ventral surfaces of the upper extremity. So we're looking at the antecubital spaces. Bigger veins in the hands should not be used, typically in geriatric patients as well. So just things food for thought, if you will, and things to keep in your mind as you progress throughout this program. All right, 2 more slides. We're going to talk a little bit about central venous access devices. In lab this week, we did show you how to do a central line dressing change. You're not going to be the one inserting this for the most part, but you will be one removing it. So we'll talk about that as well. There are 4 types of central venous access catheters. We don't really get into these in this discussion or in this course program, if you will, but it's good information to know because you will be out there using them sometimes. You'll be using PICC lines. You'll be using the ones that are tunneled in that are more permanent. So it behooves you to know kind of what's going on. Central catheters, or whatever you want to call them, you can talk about a PICC line as well. Some of you are more familiar with that. They are really the mainstay in patients requiring long-term IV antibiotics, medications, feeding, like we get into the total parenteral nutrition. They too might have a central line to make this better. Or if they're going through chemotherapy, something like that, where they have to have these medications and be accessed all the time, that's kind of what we're looking at. So unlike the peripheral IV catheters that are going in, these go into the more larger veins because they go right into central circulation. Because of the repeated use of that vein, if it's not large enough, we could cause phlebitis and other injuries to that vessel. So if you're the patient if your patient has a PICC line and it's been discontinued, you as a nurse would go in there and take it out. Of course, you would have to know how to take it out. So you'd have the patient lie flat in the supine or the Trendelenburg position prior to removal of the PICC line, because as it's coming out, you could cause some kind of vagal response and your patient could get a little hypotensive and actually pass out. They could get bradycardic. I do apologize. They can get very bradycardic and then pass out for lack of perfusion. So that's a patient safety thing when you're thinking about removing a PICC line itself. All right. Some of these will be implanted. So implanted ports, if you know what a port is, it goes underneath your skin. It gives you a place where you can access it with a big needle. So instead of trying to actually get into a vein, you have a rubberized port that you can poke through the skin in and get in. This is a lot what they use for people who are going through chemotherapy. But if you've never used a port, you'd have to get training on that first. What you need to know is that you need to palpate the port prior to attempting to access it, right? And you're going to access it at a 90-degree angle. You're going to flush with at least a 10 ml syringe to make sure that it's patent before you start administering any kind of medications in there. And once again, make sure you're looking for allergic reactions, warmth over the skin, inflammation, shortness of breath. These things are telltale signs that your patient's not handling what you're giving them and that your body's trying to fight off that because it doesn't want it. It's having some kind of adverse or allergic reaction. So, like I said, there you go. Make sure you're talking to your patient. Make sure they understand kind of what's going on to ensure that, we don't have any issues. The last point here, I kind of mentioned this earlier, is that when the patient is placed in that supine position, they're going to perform the Valsalva maneuver, which means to bear down. When they bear down, that reduces the risk of an air embolism, right? And then the catheter will be removed very quickly. All right, the last slide that we talked about in week 3 is total parenteral nutrition, so TPN. Some of you might be familiar with this. So TPN, what is it? It's all your daily nutrients. So if you have gut issues where you can't absorb, things of that nature, you could be on some bowel rest. Just depends on what your doctor wants to do. TPN is something that we typically give in the hospital, but it can be given at home as well. It just depends on if you're on a long-term treatment. Some people just won't recover from certain things, and this is how they're going to live the rest of their life. So there's a lot to know about TPN. It's very concentrated, and since it's so concentrated, it can cause thrombosis of the peripheral veins, right? So we have to have that central venous catheter. Is typically required if we're going to do TPN. So then they can go through a regular IV. They're going to get that central line that we just talked about previously. With TPN, there's things you need to kind of be aware of, right? What we want to do in real life is eat. The best way for you to get your nutrients is to eat. Parenteral nutrition should only be used when absolutely necessary, right? It has advantages if you can't eat, but the disadvantages include complications. It doesn't preserve the GI tract structure. It doesn't function as well. It's expensive, and you don't get the nutrition like you would if you ate it yourself. So this is not something that we want. It's something that is required when it's the only feasible option for the patient, right? It just depends on kind of what's going on. There are multiple things listed on your screen here that tell you certain diseases that may require TPN. More importantly for you and I, though, is try to think about TPN. It requires, just like blood products, it requires a second nurse to check it and make sure the prescription on the solution bag is what the doctor ordered. We need to monitor weights daily to make sure that they're actually absorbing and not just holding on to it and they're not getting fluid volume overload. We have to check our total protein. I told you about this earlier. The prealbumin levels are always going to be what we look for as the gold standard for total nutrition. When we talk about total protein is what we're looking for in nutrition most time, because protein is how we heal other parts of the body, especially if we have wounds, open wounds, these big ulcers on the backside from laying immobile. We know that by checking the prealbumin levels, it gives us a good idea of what the total protein levels are, which is letting us access the proper nutritional status to ensure that there's wound healing and that the patient is getting what they need. So make sure you understand that. We change the client's dressing about every 2 days on that. It just depends on hospital policy. And then the other thing we need to talk about is once the TPN runs out, it's so concentrated, it does have a high glucose content compared to something like normal saline solution. So once the TPN runs out, you would need to administer the 10% dextrose in water, so D10W, until you get the other bag. Like, so this is total parenteral nutrition. It pretty much runs daily. But if it does run out and you need to replace the bag, then you would just hang the D10W first until you got more solution. All right, so that's really it we're going to talk about this week. If you have any other questions or concerns, please don't hesitate to reach out to me. We have our test this coming week in week 4. So I will see you then. Have a great day.